Call the meeting of the board to order. Will the secretary please call the roll?
Director Curry,
Present.
Vice Chair Deere,
Deere is here.
Director Garza,
Present.
Director Guggenheim,
Present.
Director Harrington, Director Harrington, I see him that he's present. Can you hear us, Director Harrington? I'll circle back. Director Kim is absent. Director Ketting,
Present.
Director Munar,
Present.
Director Prendergast is absent. Director Ryder,
Here. Ryder's here.
thank you. And Director Story and Board Chair Taylor.
Present.
You have a quorum, and I will circle back with Harrington to find out maybe he has his speakers muted.
Thank you. And at the appropriate time, as new directors join, please make the announcement and note it. We would ask all who are not speaking to actually mute, if you would. Thank you. Pursuant to the Illinois Open Meetings Act, meetings held remotely will require roll call votes for all action items. To streamline, we'll combine the action items into a combined motion. Meetings of the Cook County Health Board and its committees will be held remotely until otherwise noticed due to the termination that a public health emergency exists. The purpose of today's meeting is to receive and discuss information on the work being done to date on the strategic plan. No action is being taken at this meeting. It is being held for informational purposes only. The next regular meeting of the board will be held Friday, April 29th at 9 a.m. The first item on today's agenda is public testimony. Madam Secretary, do we have any written testimony that was submitted to be read into the record?
Yes, we received one statement from Lynette Taylor. As a CERMAC Health Service employee of 29 years in mental health, I am grieved at the cruel treatment which I am encountering because of my God-given right of freedom of religion. I am concerned about the travesty of true democracy for every American citizen. This country was founded upon religious freedom and the pursuit of God-given rights of justice. I feel like I am being punished and vilified for requesting religious exemption. I am being demanded to defy and disobey my spiritual conscience of obedience to God, or my livelihood will be in jeopardy. I absolutely love my job at CERMAC. I am very sensitive concerning the gravity and seriousness of the pandemic situation. I have worked during the entire pandemic. I have done extensive research and received information from accredited physicians, immunologists, and my religious leader. After much prayer and meditation, I was convinced by the Holy Spirit to not take this vaccine. Since the pandemic, I have submitted to multiple COVID tests at CERMAC, Walgreens, and CVS, and I've always used proper PPE. I was just wondering why religious exemptions were denied. I've been a faithful employee for 29 years. I've been on an unpaid leave for almost 6 months, and I am in jeopardy of my pension and benefits. Per the policy, when considering the exemption request, CCH will consider the duration of the request, the nature of potential harm posed by the request. Employee Health Services will work in conjunction with HR to evaluate the work environment available, ventilation frequency, and duration of direct contact with employees, the number of fully vaccinated in the work location, etc. I am very disturbed and disheartening about the inconsiderate treatment and disregard for my faithful service at CERMAC Health Services for 29 years and also working through the pandemic. I'm asking for help and an appeal and reconsideration for my religious exemption. Thank you for your time.
Are there any?
That concludes the testimony.
Thank you very much. The next on the agenda is the environmental scan for Cook County Department of Public Health, which is being reviewed by Dr. Rachel Rubin. Dr. Rubin, are you with us?
Yes, I am. Thank you.
Floor is yours. Thank you.
Right.
Dr. Rubin, I'm pulling the file up. If you could just hold on one moment.
No problem. Yes, here we go.
And just before Dr. Rubin begins, wanted to, express the wonderful work that our public health department did in putting the data together. Of course, the environmental scan will review trends, numbers, and statistics that we should really consider as we're getting forward with structuring our strategic plan. And so we're very, very pleased by the presentation that the public health department has put for you today, and the numbers that will help guide us forward in the strategic plan. Thank you, Dr. Rubin.
Thank you for those kind words, Mr. Rocha. Okay, so next slide, please. Or I can advance, I guess. So this presentation has three main goals. It's so to develop a shared vocabulary, a shared understanding of the terminology that we're using in terms of showing these data to you, and understanding in what context those data are to be used. Also to review the health department and other public health data itself to inform the Cook County Health Strategic Planning process. And finally, to discuss patterns and themes across this data in a very quick and relatively superficial manner today, but this slide deck will be available to you going forward. And we have most of this data, or will have it most soon, on our website. Okay. Great, I can advance, excellent. So next is to show you sort of the more classical public health model for looking at factors, risks, characteristics that lead into health outcomes. So traditionally, we have been taught in public health schools to look at demographics, environment, behaviors, health system design, specific individual risk factors such as certain kinds of medical risk factors and social risk factors, and to determine how these drive particular health outcomes within a variety of different health outcome categories that you see here on the right. But that particular model, we feel, is not as adequate as it could be, because health equity and equity in general is not central to that model, even though it may be embedded in it. So I'm going to talk about that, looking at more of a modified model. But first, to give you some definitions as we go forward. So these are various definitions that are used in terms of looking at determinants for health and what affects the health of individuals as well as the health of communities, more importantly, the health of our larger communities. And certainly from a public health point of view, that's what we focus on, and how that then rolls down to the individual level. So we look at health disparities and health inequities and what the differences are between that. I'm not going to read all of these definitions. The core definition here, amongst the others, is looking at structural racism, because we tend to look at social determinants and social risk factors, which are down at the bottom of this list of definitions. And we tend to neglect or don't think about structural racism and structural determinants, because they're harder to promulgate change in those arenas. It requires really societal change. But the idea of keeping that structural racism as front and center is the way that we can design our models of the best way to move forward, even as we may focus more on the social determinants and social risk factors, to understand what structural determinants are and structural racism is. And so to read this one definition, structural racism refers to the macro level systems, social forces, institutions, ideologies, and processes that interact with one another to generate and reinforce inequities amongst racial and ethnic groups. It doesn't require the action or intent of individuals, right? So these are systemic, structurally embedded systems and forces and institutions and ideologies. And you can understand how these are very hard to affect change, at least certainly in the short term or even medium term. But this is nonetheless sort of the framework upon which we should be looking at how we approach our work. And so next is a somewhat different model with health equity as the goal. And it's a modified or simplified version of the framework created by the World Health Organization Committee on the Social Determinants of Health. And this model makes clear something that many of us sometimes. Yes.
Dr. Rubin, I apologize
Yes.
for interrupting. I can't hear when you're saying to advance the slides.
I'm able to advance them myself. Can you guys see that?
That's on your own screen. That's not for the people who are watching. Maybe.
I am so
confusion.
sorry.
No,
All
it's
right,
okay.
So can you go to slide 4?
Okay. I'm on slide 4, definitions. Yes.
Yes, okay. So this is what I just went through. I won't repeat it, but just so people will have a second to glance at the definitions. I apologize. I didn't realize that you cannot see them. All right. Oh, I clicked a little button that said see to present. Now, did that switch, or do I have to have you do it?
If you want to take control of the presentation, that's perfectly fine. Do you know how to do that?
Did that work?
Near the top middle, you'll see something about request control.
Take control. Thank you.
Yes.
You should have had a little rehearsal. Okay.
You are set.
Okay. And people can see this slide and it's on the screen?
That is correct.
Okay, so these are the definitions that I just went through. I will not repeat them. And so next, this is, as I was saying, a somewhat different model with health equity as the goal. It's modified from the World Health Organization's framework. And it makes clear something that many of us neglect to consider, that there are structural determinants of health, which I had just talked about a second ago in the prior slide. So the point is that this slide illustrates that we take together context, structural mechanisms, and the resultant socioeconomic position of individuals as structural determinants, as you see in the first box on the left. And in effect, it's these determinants referred to as the social determinants of health inequities. So this is a conceptual framework for action on the social determinants of health. So social determinants of health include in the middle box, access to healthcare, housing, neighborhood, work environment, income, access to transportation, job security, having a living wage, not just a minimum wage. So these are all things that are considered social determinants of health that then we address and then ultimately hopefully reach a more health equity or a more equitable state for our individuals and especially for our communities as a whole. So within this social determinant box, also, I didn't want to neglect that it says your behaviors, biology, and psychosocial factors, which tend to be neglected, but we are trying, certainly within Cook County Health and Cook County government, to put a brighter spotlight on that particular bucket of social determinants and social risk factors. So these social determinants then create a series of social risk factors that work hand in hand with the social determinants. Okay, next slide. Now to get into some of the demographic data. So this will go through I will go through fairly quickly. You will have all of these slides. The first one here for you to see is where just distribution of our racial and ethnic groups as of 5 years ago, 6 years ago. And as you can see here, the highlight of this is to show that we live in segregated communities. I would imagine that if we were to overlay this from a map from even 20 or 30 or 50 years ago, it would be even more segregated than it is now. But you can see that there are not very many communities that are significantly mixed racially and ethnically, and that has maintained itself throughout long historical imperatives in the Chicago and suburban areas of Cook County. So you can see here predominantly we have our Latino populations are generally in the central west part of the city as well as the near west suburbs. There are a couple of pockets out in the west. There are a lot of migrant Latinx workers who worked out in Arlington Heights at the racetrack, and so there are smaller communities out there that have settled. And you can see here that the predominant African American communities are the west side pocket and sort of middle to far western suburbs, and then the south part of Chicago as well as the south suburbs, with a few pockets of predominantly white and a few other Latinx and other populations mixed in. But again, it's still relatively segregated.
Dr. Rubin, you have a question from Director Harrington.
Oh, yes, Director.
Director Harrington, you're muted.
Director still cannot hear you. Director, we can't hear you. I'm sorry.
Director, we still can't hear you. We'll come back to you. Please just put it in the chat when you're available.
Sorry, I had skipped ahead by mistake. Okay. And the next slide is looking at where we have limited English speakers. And you can see the predominance of that is within the city of Chicago, but we certainly have pockets throughout the suburban areas where there are limited English speakers. And so it's fairly widespread. And this is something that we also obviously need to be paying attention to with respect to equity and addressing how we deliver care. So now looking at social determinants of health, so access to care. This is interesting with respect to especially comparing the city to the suburban areas, is that, sorry, I'm getting onto my notes here. Okay, so what's interesting here is that all of the dots are where we have hospitals, and the hospitals, licensed hospitals, are predominantly concentrated within the city limits. But as people know, almost as many people live in the suburban areas as the city. And so in the suburban areas, we have really a lack of specialty care services, at least as widespread as we need it. And we're spread over a massive landscape of over 700 square miles. A lot of people that live in the suburbs will go to the city for hospitalization, but that's not necessarily the best way to approach equity in care. And then we need to have hospital care and outpatient care that is proportional to the population, and also services proportional to our higher risk populations as well. And there is major disparities with that between the city and suburban areas. Medically underserved. Now, this is predominantly a excuse me, a framework that's split up between medically underserved areas, which are in sort of the maroon color, the medically underserved populations, which are in the mustard color, and then these are governor's exceptions. So what this means is that the darkest color looks at underserved areas, so underserved geographic areas, meaning where there is lack of medical care and other healthcare services. And the highest areas are, you can see areas of the city that have been considered underserved areas. The central and western part, as well as certainly in the southern part of the community of the city, as well as you can see in the suburbs, are the most highlighted. And medically underserved populations are spread out, but you see medically underserved populations in the north and west and south areas. So these are actually populations. So these have to do with groups of individuals, such as lower income communities, low English speaking, etc. And then there's the governor's exception, and the maroon and the mustard colors are what are designated by the Centers for Disease Control and Prevention. The governor then is allowed to specify within his or her own state additional areas that are considered underserved areas that lack medical services. So again, it's underserved areas. And so our governor has designated other areas that basically include the majority of the Chicago city, and then some smaller areas of the city, of the suburbs, especially in the north. How the governor determines these and which governor did this, whether they've been reviewed over the last couple of years, I don't know. It is a relatively newer designation, and I can certainly get more information on that if people would like. Is there a question out there? I couldn't tell.
I think Dr. Harrington, Mr. Harrington, Director Harrington, is your mic working now?
Can you hear me?
We can.
Yes, we can.
Okay. Yeah, I recently purchased a new computer and I had to check my mic settings. So I'm still learning how to navigate. I have three questions. I'll defer to Mike Ketting, Director Ketting. You may have one, and I don't want to take up a lot of time. So I'll defer to him and then you can come back to me.
Okay, Director Ketting.
Thank you, Joe. I just want to point out that it's kind of disjunct between the last two slides you showed, in that the medically underserved areas are right in the middle of the tightest concentration of hospitals. And whereas you called out a lack of hospital resources in the suburbs, very few of the medically underserved areas are out there. So it just suggests we need to be fairly nuanced in our thinking about what really are medical resources, what leads to undersourcing, and overall we have to also think about what's the most efficient way to provide health care. And it has lots of ramifications, and I'm not going to spin through them all, but it just is another reminder that any one piece of this we look at probably isn't sufficient to shed much light. It's when you look at them all together.
No, I agree, and I certainly support that comment. And I realize myself, as going through these, that there is that mismatch. And I think it has to do with also what the CDC and their metrics and how they look at our communities versus how we look at our communities. And you're right, we need to be more nuanced and more sophisticated in how we explain this.
Well, I'll come back with my three questions. Slide 3 was on health outcomes, and I don't want to take a long time. And were those health outcomes, were they a rank order or a priority order? Because it started with infant mortality, and I didn't know if that was based upon the prevalence of disease or the issue, but I assumed it was something that a group established as a priority order.
It's not necessarily a priority order. These are the lists of determinants that are considered sort of the standard metrics that have to be captured for public scrutiny.
So those are standard. So there's no other than the fact that these are common issues. It could be alphabetical, could be anything.
Yes, correct.
Okay, and in slide 7, it was map 2, the color-coded legend. There was a degree of, there were 2 colors, and I couldn't figure out, there was some shading, and I couldn't figure out what that meant. See, non-Hispanic black has.
Why do they have 2 different shadings? That's a good question. Right. I think it just has to do with probably the penetrance of that population in terms of percentage. Okay. So even though, for example, in the far south, it is predominantly African American, there's more of a mix there than just a little bit further north.
Okay.
But the blue is darker.
That's what I thought. And then slide 11, I think that's the slide that you were currently on it, or just before access to care. And looking at this map, it seems like the areas for the medically underserved are consistent with this issue of African Americans and Latinx. Those are mostly communities that are comprised of African Americans and Latinx. Is that correct based on looking at some of the previous slides?
Yes, yes. Because we're
Okay.
talking about geographic areas, yes.
Yes, thank you.
Excellent comments so far. So next is looking at the distribution of households that are living at or below the federal poverty level in Cook County. So the darker the color, the darker the blue as you go from yellow to aqua down through dark blue, means a higher percentage of people in those communities are living below the federal poverty level. So again, this corresponds to the other maps that we've been seeing, is it's the west side and near west suburbs. And then as you go further south into the south part of the city, as well as in the Southland and the suburban areas, as well as down here in the further far south, are the areas that have the highest concentration of people. As much as over 50% of individuals in those dark blue areas, the population, more than 50% of those populations could be living below the poverty level. Between 23 and almost 60% in those communities are living underneath the poverty level, which is, let me see, I even had what that, excuse me. And so I think the poverty level for a family of 4 is something like $27,000 a year at the moment. And we know that that is a ridiculously low number. Okay, so life.
Okay, this is Director Curry. Could you go back to that slide again? Previous slide. Just wanted to ask the breakpoints that we're showing here that differentiate the colors, the magnitude of the poverty levels. Are those reported by the feds, or did we kind of set these up ourselves? I know there wasn't a consistency between the percentages or.
Right. No, this was set up, if you read the legend, which I know is in very small print, the reference, it's from the U.S. Census Bureau from the American Community Survey from 2012 to 2016, and we're in the process of doing the next survey.
Okay.
I just want to make a quick observation in looking at this slide, that it appears that probably another way to put it is the wealthiest communities are outside of the city of Chicago, and the ones that have the highest burden of poverty, with the exception of the southwest, near and southwest suburbs, are totally in the city of Chicago for the most part.
Yes, for the most part, you're absolutely correct that it's mainly in the northern part and the far western part of the county outside of the city of Chicago, and maybe small pockets within the city of Chicago
Thank
that
you.
are the highest income levels. Yes. Okay, and next is looking at life expectancy at birth, and if you switch back and forth, it looks pretty similar. If you were to overlay these two, and life expectancy, and these are 2016 estimates. We don't yet have the 2021 estimates. Those will be coming out eventually. Once the census gives us all the right denominators, then we won't get those until sometime next year. So this map shows the relationship between life expectancy and neighborhood level poverty. So obviously, if you live in a more impoverished community, your life expectancy is lower. So poverty has been categorized as lower or higher than 15% of the households in a neighborhood being at or below the federal poverty line. So basically, the higher your poverty, as we know, the lower your life expectancy. And this illustrates that indeed that is borne out with the data. And next is looking at unemployment amongst individuals 16 years of age and older in Cook County. Again, of course, this correlates with the most impoverished areas of the community, but not entirely. Like you look here in the West, you know, most people actually, many people have employment while those are also impoverished areas, implying that, excuse me, that there are areas where there's relatively reasonable employment, or let's say the unemployment rate isn't extremely high, But these are very low wage workers. So this is where our essential and our low wage workers come from, are in the areas that are in the Southland and in the West Side, where they are still considered impoverished communities, but they have a better level of employment than some other areas. So that's where it comes into what is a living wage. So this is households that are receiving SNAP benefits. So that means they have met the income requirement to receive supplemental food benefits. And then this is looking at uninsured individuals, uninsured with respect, obviously, to medical care. In Cook County, and this is since 2016, 5-year estimates. And you can see here there's many more people that actually have insurance than you would expect based on poverty levels, and that's, of course, because of Medicaid expansion. And the areas that have the lowest level of insurance, which are these darker areas, probably correspond most predominantly to our higher immigrant communities who do not qualify for the public form of insurance, much less private insurance. So these could be undocumented or individuals that have been in the United States and have green cards, but they've only had them for under 5 years. So there's some pockets of underinsured and no insurance that we need to be focusing on within the city and then in the suburban areas. Okay, and next, child opportunity, and there's a special child opportunity index. It's actually, as we say here, it's a composite of measures of neighborhood-based opportunities with respect to education, health and environmental opportunities, and social and economic opportunities. And you can see again where these are. It's in our west and near west city, near west suburbs, as well as the Southland in the city, as well as the suburbs. And one thing I wanted to highlight, maybe because I'm a specialist in occupational and environmental medicine, is to point out that we also talk about toxic exposures and to see where are our dirtiest environmental workplaces, industrial places, and they are generally a lot are in the south and in the south part of the suburbs. There are some out here in the west as well, and these are where the most polluting workplaces are, and where you have the most toxic substances have been deposited in the air and the water and the soil. All right, so next we're going to look at health outcomes. So looking at specific disease categories, and you'll see similar patterns. This is for heart disease, age-adjusted mortality for heart disease. Again, it's interesting in the central part of the city and then trickling down through the south areas, as well as a little pocket here in sort of the central west. And we look at stroke and cerebral vascular disease, just to jump back a little bit, very similar patterns. And these tend to go together. For people that get so-called heart attacks and myocardial infarction, it's the same disease process generally that also causes stroke and cerebral vascular disease. So they are going to be parallel with each other in many instances. Now, this is looking at cancer. And what's interesting is you see clusters of higher levels of cancer in the far southwestern suburbs and the northwestern suburbs. And this is also where there happens to be heavier industry and potential polluted areas and what are called Superfund sites. But then there are also areas within the city itself that look at higher cancer mortality. And this is all-cause cancer. So it's not splitting out for breast cancer versus lung cancer, etc. Looking at diabetes, it's again, we see a lot of diabetes in our Southland and south part of the city, a small swath here, and then in the west and near west areas that show diabetes. Diabetes tends to be especially high in our Latino, Latinx communities, and that could somewhat parallel. That doesn't explain it all, but that could be some of the disparities that we are seeing here. And asthma hospitalizations, you'll see here, all areas. It's very interesting in the near south and southern parts of the city, as well as the Southland and West areas again, and then western suburbs. You see asthma hospitalizations, and this is asthma emergency department visits. So these are people who may not necessarily be hospitalized, but they come to the emergency room for treatment of their asthma, which another thing that could be estimated, and this is for adults, is that this could also be people that don't have primary care physicians and cannot readily get in to see their primary care physician. So they use an emergency department for care for their asthma. Suicide and self-inflicted injury amongst adults. You see this large pocket in the far south area, western areas of the city and the suburbs. And this is for children. So here it is for adults. And then here it's interesting for children and adolescents. You see these large pockets in the northern suburbs, as well as in the sort of southwestern suburbs as well. So very interesting phenomenon. And mental health emergencies are similar to what we saw in the adult suicide prevalence. Okay. Okay, and then this was for substance use. Basically, where we were seeing substance use emergency department visits per 10,000 population in suburban Cook. And you see it's in the west side of the city, in a southwest pocket or a south central part of the city, because this is the city boundaries there, as well as all throughout the Southland and the southern suburbs. You see substance use as being resulting in emergency department visit rates to be quite high. And alcohol use is a little bit more widespread throughout the city, and then again in sort of southwestern, near southwest areas of the suburbs, as well as fairly spread out through a variety of different communities within the city limits. Very little in the north. That doesn't mean that alcohol isn't necessarily a substance use issue in these communities. They just don't make it to hospital emergency departments. And this is opioid incident. This map is a little old. We were trying to find a newer one, but for now, and this comes out of medical examiner office data, is that you see the vast majority of opioid incidents, overdose incidences, have been in the western part of the city. So in the western zone, as well as spread out in other areas of the city. And then there are a variety. It's spread out throughout the suburban area. It looks like there's less in the city, in the suburbs, but there's actually a fairly high rate of opioid overdoses in the suburbs. It's just that the geographic area is so much larger than the city. It's more spread out throughout throughout the suburban area. You don't see as many clusters, the sort of darker blue areas, maybe a little bit around here. Okay, and estimated life expectancy at birth, similar to the slide I showed before, which shows that the life expectancy in the northern part of the county is between, excuse me, this shouldn't be 90 to 82. It should be 80 to 82 life expectancy at birth. So that's not controlling for childhood childhood deaths. And so this is your life expectancy at birth. And the highest rates are between 80 and 82 in the northern parts of the county. And you see the lowest levels are in the central and western parts of the city, in certain areas, especially in the far south, where life expectancy is from 60 to 73, so 60 to 74. Actually, oh, I see what it is. I was reading this backwards. So actually, life expectancy, so this really tells you the gap. So in the north, life expectancy at birth is between 82 and 90 years of age. And then you look here in the central part of the city, as well as in the far south, life expectancy is 60 to 74 years old. So 15 to 20 years difference in life expectancy between the northern part of the county and the southern and sort of central city part of the county. Quite stark.
It is. Dr. Rubin, I think we have another question. Director Harrington, your hand is raised.
Yes.
You have a question?
Yes. An earlier slide, you talked about mental health and talked about mental health emergency. What constitutes a mental health emergency?
I think that that's where when anybody presents to an emergency department where the chief complaint or diagnosis is a psychiatric complaint. So it's not somebody who comes in with high blood sugar and they are listed as a diabetic emergency, even though they may also be having depression and that's why they're not taking their insulin. So it would have to be coded into, this is something that's called syndromic surveillance, and this is how a lot of this information is collected for these particular graphs is looking at emergency room, emergency department keywords in the chief complainant and diagnostic codes of emergency department visits.
Yeah, and slide number 1, where you discuss opioid deaths, and I pointed it out before that unofficially the Eisenhower Expressway has been dubbed the heroin highway, particularly because of the amount of heroin sold on the near and far west side of the city of Chicago.
Yep. And I think that that is fairly consistent with the graphs. Okay, next talking about structural racism in health, getting back to that definition. So this is a quote from Shirley Chisholm, who was the first African-American woman to run for president in the United States. She says, racism is so universal in this country, so widespread and deep-seated, that it is invisible because it is so normal. It's become normalized, so we don't see it. So we need to be making that visible. So I'm not going to go through these quotes. These are different professional societies and their consensus, excuse me, their consensus about race and racism and discrimination in terms of access to care. And especially just the first one from the American Nurses Association, that nurse administrators are encouraged to look beyond the immediate environment to the wider community for opportunities to contribute or participate in efforts to promote health and human rights. So it's to look beyond our immediate environments, to look beyond our what we can see right in front of our face, and to look at our communities and to look at the underlying structural underpinnings of the discrimination that goes on. And these are a variety of other professional organizations that have other kinds of sort of consensus on embracing and understanding what structural racism and the social determinants and social risk factors are. So that includes the American Nursing Association, American Association of Family Physicians, American Association of Pediatrics, American Public Health Association, the AMA, and the American College of Physicians, amongst others. But these are sort of the prime medical and healthcare organizations in the United States. So life expectancy at birth, I showed this before, and I'm showing it again to provide a context within this particular section about looking at structural racism. So we can see here that the further south you move, the lower your life expectancy is. So place matters, and poverty matters. So this is again illustrating exactly what was seen on the slide, but you can see it graphically, is that the higher your income, the longer you're likely to live. So people living in areas with a median income greater than $53,000 per year have a life expectancy that's almost 14 times longer than that of people living in areas with a median income below $25,000 per year. So income is a powerful driver of health. But you also have to remember that even if you control that, but to understand also that if you are a high income African American male, for example, your life expectancy is still going to be lower than a high income earner white male. Okay. But overall, this trends according to income, But if you then overlay other kinds of racial and ethnic characteristics, you see that some of that has a little bit of nuance to it. Okay. So,
Director Aaron, did you have another observation or question? I see your hand is raised. Okay.
oh, okay. So this is racial gap in household income. And as you can see here, Asians and whites, Caucasians, have, this is median adjusted household income in 2014. So that was 8 years ago, 8 years ago. And you can see here this huge gap between Asians and whites that are at the top and Hispanics and blacks that are in the lower here. So this gap is over $30,000 a year for an average household, which I think is generally 4 people. Okay. So this is, another stark illustration of that. So life expectancy, again, for high-income African Americans is still lower than that for high-income whites. And that's because you also see that there is a continual gap. Okay, and this is sort of a complicated slide. The take-home message about this is most people have heard by now, probably because we've brought it up several times in different presentations, about redlining. And this is where people were able to get low interest mortgages so that they could purchase their own homes. And the red areas are those areas of the city of Chicago that had large areas of redlining. And I put in a little marker in here that this is 35th Street, is the top edge of where you start seeing the red census blocks. 35th Street going south through the south area, this is Lake Calumet, and then going into the south suburban areas as well. And you see just a little bit of blue, and this is where you could get decent mortgages and with decent interest rates. Okay, and the yellowish areas are where neighborhoods that were in the decline, and these areas that were in the decline were the ones that are bordering the red areas where the predominance of the redlining was going on. And who lived in these redlined areas? Predominantly African American populations and communities. So to understand that this was from 1934 to 1968, but it's not like we have advanced that further. There may not be necessarily the same level of redlining, but lower income or moderate income individuals have a much, much harder time getting mortgages. And we know all of the stories of people who don't speak English, whether they're Latino or other immigrant populations or African American, have much less ability to find a bank that will loan to them. Okay, so structural racism and health inequities. This comes from a paper by Bailey and Krieger, who are social epidemiologists, well-renowned social epidemiologists in the United States, called America, Equity and Equality in Health, 3 structural racism and health inequities in the USA. So to show the main structural forces at play here are economic injustice, lack of access to health promoting environments, whether it's open spaces for walking, safe spaces, so safe streets, healthy streets, environmental and occupational health inequities in terms of pollution, workplace health and safety being less than adequate, especially amongst our lower wage workers. Targeted marketing of health harming substances. So in terms of cigarettes and the whole thing about e-cigarettes right now. Lower access to quality health care. Political exclusion, so not having power within your communities, not having power to force change societally through elected or through progressive movements, mass incarceration, and regressive educational funding policies, which we all know about, where if education is based on the tax base of your community, that means poor communities are going to have less money available for education for their children. So, excuse me, In summary, just finishing up here, um, we have a long history of discrimination and racist policies that just disproportionately affect residents, and it's predominantly our west and southern parts of Cook County that includes in the city as well as the suburban areas. So low access to the social determinants of health and higher social risk factors resulting from that for diseases and poor health outcomes are resulting. Um, so this has created many areas of concentrated poverty and low opportunity in our communities. Populations who live in these areas experience worse health outcomes. We know that. Many individuals from these populations are our patients, especially those that will utilize the Cook County Health System. So the data that I've shown you today, it sometimes appears sort of impersonal or cold and overwhelming. It doesn't have sort of the stories behind it that you can all imagine. However, we must acknowledge that allowing ourselves to be overwhelmed by these data is actually a privilege, and that we must turn our knowledge in this data into action. So the strategies for healthcare, the things that we are trying to promote, are a variety of recommendations to make health equity a strategic priority. So equity is a strategic priority. So develop structures and processes that support that work. Deploy specific strategies to address the multiple determinants of health and social risk factors of health. So to decrease institutional racism within our own organization, at the same time that we identify ways for our organization to decrease structural racism, we should also acknowledge the institutional racism that may be embedded unintentionally, but nonetheless embedded in our own structures. And to develop partnerships is very key with community organizations to promote health and equity for our communities and for our populations. So as an anchor institution, healthcare organizations, including Cook County Health, really can create influences on employers and on the economic community in a number of ways. For example, English language classes to employees who are not proficient in English, or providing time off from work to take those classes, to give paid sick time, and to have a living wage for people, to procure supplies and services for women and minority-owned businesses, to build healthcare facilities in underserved communities. So these are all things, even within a health structure, a health provider structure, and a public health structure, that we can support and push these kinds of policies that will result in decreasing the adverse effects of health inequity. Okay, so to end with a quote by Ta-Nehisi Coates, we must never look away from this. We must always remember that the sociology, the history, the economics, the graphs, charts, the regressions all land with great violence upon the body. So when we're looking at these graphs and they seem sort of impersonal, we look at our history, we look at the economics, it does come back to being embodied in our health and our well-being. And this is just some thank yous to some of the folks that helped get all of our data together, either the sources we used or the staff that we used to put this together. And of course, last but not least, the Cook County Health System in providing me with this opportunity to speak to you today. So thank you so much.
Thank you very much, Dr. Rubin. That we do have a number of questions or comments from some of our colleagues. First, I'd like to acknowledge Director Pendergrass. Acknowledge that she's joined us and she's here, and acknowledge her for the question or comment.
Okay, thank you so much, Chair. Thank you so much for that presentation. I think that we cannot overstate the importance of social determinants of health. I don't know why this is echo, I apologize. But I think that, if we failure to do that, we essentially will operate with blinders on. So I think this is critically important. Thank you for this presentation and walking through it, because we absolutely have to address the impact that the social determinants have on a healthy on health and just having a healthy community. So just wanted to say thank you for the presentation.
Thank you. Next, Director Harrington.
A couple of things there. There are observations, and I did send Debbie an article about anti-racist action. It was a recent JAMA article that some of my colleagues actually pulled together. But I want to provide some personal background because I grew up on the south side of Chicago in the Woodlawn community. My grandfather actually purchased the house that I grew up in 1940. What made that possible in a sense, because Dr. Rubin talked about redlining, but redlining was preceded by restrictive covenants, which was the law, and Black people couldn't live in certain neighborhoods. And what made it possible for Black people to move into those neighborhoods was a Supreme Court decision. It's the Hanbury versus Lee decision, which occurred in 1940. And when we mentioned Hansberry, it was Lorraine Hansberry's father, the author of A Raisin in the Sun, that sued. Went to the state Supreme Court, which affirmed restrictive covenants, then went to the Supreme Court, which said restrictive covenants were illegal, which allowed African Americans to legally move into the community. However, there was this informal practice of redlining that prevented African Americans from moving into the community.
Director Harrington, thank you for highlighting that for us. And Dr. Rubin, I'm sure that's some of the things you're taking into account as you develop the study. Director Curry.
Yes, mine is a comment. Great presentation, a lot of solid information that will help us as we continue to dig down. I wanted to get your impression because some of the 5-year estimates that were done for the period 2012 to 2016, do you have any sense or any anecdotal consideration for what's moved in these last 5 years? Has the needle moved in the right direction? Hasn't moved at all? Gone backward on any one of these that you think may be more significant than the other?
You know, this would be somewhat speculation because we haven't done the next 5-year survey. The federal government has not done that, and we do our part at this end of the country. But I wouldn't be surprised, at least over the last 2 years, the economic situation, despite the more recent Better Jobs reports, is that people have suffered tremendously economically. So I would imagine that the gap has probably widened a little bit.
Yeah, I wouldn't be surprised either. Thank you.
Sorry, do we have any further questions or comments? Thank you, Dr. Thank you, Dr. Rubin. Appreciate it. Next, Andrea Gibson will now review. Andrea Gibson will now review the next item on the agenda, which is the summary of stakeholder feedback and the strategic planning update. Andrea.
Thank you, Chair Taylor. As Debbie pulls up the presentation, what we wanted to do today is talk through what feedback we received from the various stakeholder meetings that we conducted over the past month. Looking at our schedule, that's our one of the topics for today as we move towards finalizing a strategic direction and plan. So the items that I have in the presentation are listed here. I think, we have half an hour, so we'll have to make a decision at some point if this continues on to the next meeting or if we go through it. For the stakeholder feedback, we met with community members, employees, labor representatives, the Board of Commissioners, and asked for help identifying what they thought our strengths, weaknesses, opportunities, and threats are. And that's what I'm going to walk through today. For the community town halls, we had 140 individuals register. We had 4 meetings, one in Spanish, 2 regular community meetings, and 1 with our community advisory groups. The feedback we received, and you'll start to see some themes, is they identified that our strengths include providing services to everyone, the quality of our medical care, the focus on health equity. Our weaknesses identified in the community meetings included wait times for services, limitations of the CareLink program, availability of patient transportation. Opportunities identified were investing further in behavioral health, expanding the use of community health workers and peer counselors, and providing additional services and clinics. Threats identified in the community town halls included limitations of external transportation systems, the redetermination issue around county care and whether and when that starts, potentially moving some people off of Medicaid managed care, and housing issues and helping address those and acknowledging the link to healthcare. We also did a survey to the community, and we received about 100 respondents. Some similar comments again. Our strengths were identified as our commitment to serve everyone, the quality of our medical care, and the level of community engagement that Cook County Health undertakes. Weaknesses identified included administrative processes, customer service, access to specialty services, and staffing levels. Opportunities identified in the community survey included expansion of partnerships and integrating with other providers, adding mental health services to our existing foundation of mental health services, and addressing housing and food insecurity. The threats identified in the community survey included, access to financial resources and potential impact of the economy, and healthcare recruiting overall, as we all know well that there's a nationwide challenge to recruit within healthcare. And then another item identified was the pace of some of our implementations of alternatives to traditional care settings. So telehealth we did implement during the pandemic, but there are probably other areas like in-home healthcare and some alternatives to traditional service delivery that were identified as, we're a little bit behind according to the community survey. So that was the community input. For the employee town halls, we had 450 participants. Again, the strengths included providing services that are needed, the medical staff and the care that's provided. Weaknesses identified were recruitment, retention, process improvements, accountability, responsiveness. Opportunities included community partnerships, expanding telehealth, extending hours, and establishing urgent care. Threats identified included healthcare recruiting and aging facilities. For the survey, what we heard from employees is that a dedication to the underserved was a strength of the organization, along with quality of care, clinical expertise, and the ability to mobilize for new circumstances. For example, the mass vaccine sites. Weaknesses identified included the patient experience, perceived bureaucracy, lack of flexibility in certain processes, staffing, retention, and recruitment, and role definition and accountability. Opportunities identified include leveraging federal dollars for investments, service line development, especially for specialty services, capital planning and investment in facilities and equipment. Threats include future pandemic surges and processes that put CCH at a competitive disadvantage. And patient choice was also identified as a potential threat, as individuals can make their healthcare decisions and go to other locations. We also had a discussion with our labor partners and received some feedback on strengths, weaknesses, opportunities, and threats. The strengths identified in that discussion included our response during the pandemic, working for a historic institution, having the ability to serve the community, and having a unionized workforce with decent wages. The weaknesses identified by this group included recruiting, lack of part-time options, flexibility, training and cost, trust training availability, and promotion opportunities. Opportunities included more preventive care, succession planning within the organization, bilingual service expansion, and patient appointment scheduling. When we met with the Board of Commissioners, the strengths identified there included the providing services to everyone. And actually, it's on here, improving internal processes was identified, which related to revenue cycle and I think standing up the mass vaccine sites. And community engagement, doing a good job of getting out there with community groups and engaging with the community. Some weaknesses identified include access to specialty care, having extended hours, and some conditions of the facilities. Opportunities included increasing the marketing availability, telehealth, mobile health care, having alignment across public health agencies, developing a workforce pipeline, community-based, that is, expansion of other services. The threats identified in that meeting included the Cook County population decline and then redeterminations for county care members. So I tried to go across all of that input and try to pull out common themes. So I took, it seemed like every group of stakeholders identified commitment to serving everyone, regardless of the ability to pay, as a strength. The quality of medical care was also universally mentioned. In terms of weaknesses, staffing, retention and recruiting, administrative process improvement, facility conditions, and access to services, which included a number of things: wait times, transportation, scheduling. For opportunities, it seemed as though there were a lot of comments around expanding mental health, addressing housing and food insecurity, partnering with other organizations, expanding to have new approaches to care, like with telehealth, and expanding specialty access. Threats include recruiting in healthcare right now and redetermination. So I wanted to pause there and see if the board of directors had any comments on what might be missing or what they think they would like to underscore in the strategic plan. Any comments on the SWOT analysis? It looks like there's a hand up. Hold on. Oh, Director Curry.
Director Curry, you're still muted.
All right. Under the heading of administrative processes, which I see cuts across all the different surveys, you'll probably have an opportunity to dig a little more on what specifically is being referenced there from a priority order.
I did look at that, and some of that includes the hiring process, procurement process, but also registration processes, and even billing. So a lot of different things, but I group them into administrative processes.
Thank you.
Hey, Andrea, I'm on by phone. You can hear me, right?
I can hear you, although, do you mind
Okay.
identifying yourself?
Oh, yeah, Director Garza. Sorry about
Okay,
that.
hi, Director Garza.
Yeah, no, I thought we knew each other well enough. I know it's always hard by phone. No question. I just want to make a comment that I really do appreciate the focus on better integrating the care, and especially trying to leverage I guess the ability to work with partners in the community. So I just wanted to share that with you, and no other questions, just that one comment. So I do appreciate the work. I know I raised it last fall, and it seems like there's a lot of intention around trying to make the most out of the relationships in the community, as well as having a focus on integrating the care within the system.
Great, thank you, Director Garza. Director Guggenheim?
Yes, I want to make a comment about the strengths, because I agree that the quality of medical care is a huge strength of the system. I think the notion that people identify the commitment to serve everyone regardless of ability to pay is actually a little strange. I mean, I think what people are saying when they cite that as a strength is that they applaud our value system, because the commitment to serve everyone, one could argue in economic terms, is in fact a weakness, because we have relatively few people who are well insured in our patient population. And that results in the other sort of weaknesses that are identified, and the difficulty over, recruitment and compensation and everything else. So it's a bit of a knee-jerk response that we always say commitment to serve everyone is a strength. It's a reaffirmation of our values, but I don't know that it's in any concrete sense a strength of the system. I mean, I'm not arguing against it. Yeah. I'm just saying it doesn't really make any logical sense. So I think we ought to be careful in interpreting that.
Yeah, I think it's almost analogous to what people like about us, is maybe another way to put it, but right. Understood.
Right, but it isn't really a strength of the organization. You see what I mean? All right, enough said.
All right.
Yeah, I think.
Go ahead. Sorry.
No, I was just gonna say. I think you're correct. It's a strength in that you can practice medicine freely and care for everyone. It's a challenge in how we pay for it, and it cuts across many different things that I know we want to talk a little bit about more later. But I agree. Thank you for raising that, because it is a strength and a challenge and an opportunity and a weakness and a threat all at the same time.
All right. I don't know who's next. I think possibly Director Ketting.
Yes.
Yeah, this is some way in the same part of the forest as Mary's comment, but under opportunities, when we say addressing housing and food insecurity, and also to some extent expansion of mental health, those are things that could certainly be done. They need to be done, but are they really an opportunity? And in what sense are they an opportunity? We kind of need to think through what's the goal, and do these help our business situation? Do they help our political situation? Do they help our moral situation? But they're not an opportunity in the same way that I think expansion of specialty access is.
Okay. Understood. Like you could put a lot of these in multiple categories, and those could be considered. The way they were presented in these meetings was that would improve the overall health of our patient population if we helped resolve some of those issues. But potentially those could be in weaknesses, right? Like they could be in multiple categories. Director Harrington, I understand you're next.
Slide 7, there was community survey. And one of the things I guess in a sense I was disappointed about, because it appears that we sent out 23,000 surveys to individuals and we have an open rate of 30%, which would be 3 out of 10. But if we only sent out 100, that's a pretty low response rate. So I'm assuming that the people that completed it were highly motivated to complete it. So it may be a distorted view of where we are. That's all.
Well, I understand from the experts that it's typical to get about a 20% open rate. So we had a higher level of response rate than what is typical with like an email distribution of a survey.
Yeah, I think with 30%.
Yeah, I was going to say that sounded like a high.
Yeah, maybe it does.
Yeah, I was going to say, based on the statistical stuff that I've worked with and pulling things like that, that the consumer data, that seems like really, really good. And that'd be 30 out of 100. So.
Anything else, Director Harrington? No. Okay, Director Munar.
Thanks so much. Yeah, my comment is similar to Director Guggenheim. So we've been working a little while together. I think that I guess I'm receiving these as the stakeholder feedback. I guess I'm lamenting that that one of the strengths of our stakeholders isn't that we're a good value. And I wish that was a perception of the system, because I think that the regardless of ability to pay sentiment often is viewed by our constituents as kind of the provider of last resort, which I think is also actually disadvantages us. And those who have options to get their care needs met somewhere else may do so, and wouldn't if they saw us as a great value, because I think that would incentivize people across the income spectrum or payer classes to elect us as a care provider. So I understand that this slide may be very focused on just what the stakeholders said, but I think it's interesting that that our care is not perceived as being of a good buy, and that's unfortunate. And I think that's something that we should focus on.
Thank you. Shall I go on to the next section, Chair Taylor?
Please do, and I think that directors and others just note that we are scheduled to conclude at 3 p.m. So what I would suggest is to let Andrea cover the next section, and we'll recess the meeting at that time, and then continue the discussion and review. Andrea?
Okay. Yeah, and this is information. So you have this document, and it's a lot of data, and so it's perhaps worthwhile to review offline, prior to the next meeting. So I'll go through it just so you have an understanding of what's in it.
Yes.
But this section, sorry, I advanced quickly, gives you some information on volumes, utilization, and it generally goes from 2019, so pre-pandemic, to recent information. And you can see on here, the red line is the 2022 information, and the darkest teal is 2019. So if you recall from the budget, our goal was to try to get back to pre-pandemic levels. And so you'll see, mixed results on that thus far. So inpatient discharges trend over time, and you can see that we're greater than we were a year ago, but still below the pre-pandemic pre-pandemic timeframe. Emergency services trend is lower and continues to be lower, where we are post, where we are in the pandemic. So there's speculation about if we would return to pre-pandemic levels in the emergency room, or have we shifted in the care that we provide in terms of emergency services. Outpatient primary care visit trend is also, we're below where we were a little bit, and below where we were last year. Looking at the specialty care, we're about on same pace as last year, but still well below the prior to year time periods. Looking at the next slide, you'll see, and payments lag behind by 1 month. You'll see this little red dot. We just showed you where we were volume-wise during this time period, but our payments made it's higher than all of the other time periods, and that relates to a number of factors, including better rates, improved revenue cycle process, etc. So I thought this was interesting. This shows top diagnoses, diagnosis codes from the last time we were considering a strategic plan compared to 2021, so 2018 to 2021. The main change, the number one diagnosis in 2021 was immunization. So that relates directly to providing the COVID-19 vaccine. And also the appearance of 2 diagnosis codes that relate to mental health. So anxiety disorder and depressive disorder show up on the top 10 diagnosis list in 2021, and they were not present in 2018. And that's for outpatient services. When you look at inpatient services in 2021, the number one was COVID-19 as the top diagnosis code, and a couple of areas from 2018 related to COPD and pneumonia aren't on the top 10 list, but all of the other ones remain fairly consistent, even if the order has shifted. One of the things since we last did a strategic plan is the payer mix changed slightly because of the expansion of Medicaid to the undocumented populations over 65, and coming up soon, those over 55. The market opportunities that I wanted to run through, just looking at through a few different lenses. First, I wanted to share the hospital admissions with related hospitals, or in Cook County hospitals, and there's overall a trend to reduce the number of inpatient admissions. We have maintained the market share, even though the numbers have gone down since goes back to 2008, and Provident changed dramatically in this window of time, just because in 2011 we no longer accepted ambulance runs. Looking internally, like we refer patients for services And we've done a fair amount of work recently. And in fact, I think at the last QPS meeting, there was a review of looking at all of the patients who are waiting for appointments and services. And so these are some internal numbers of where we have an opportunity to serve more people, even though, you know, they're referred internally and they just are, they have a long wait time. The backlog progress, and again, this was in QPS, there's a number of different strategies underway, including trying to maximize the sessions, improving scheduling, double checking for the queue for duplications, and whether it could be the referral could be served by e-consult. Secondly, there's an opportunity to keep some referrals at Cook County Health. We looked at the number of referrals out that we made in 2021 that show, you know, physical therapy, mammogram, orthopedics, those are all referred out. Those are the top 3. But you can look at this whole list on referrals we make to other institutions. And then we also reviewed information from an organization called the Advisory Board, which is a healthcare consulting firm that compiles trend information based on information from literature reviews and analysis and monitoring the market. So this first slide shows inpatient trend and projections. I should say projections 5-year and 10-year. So not surprisingly, most inpatient areas are not projected to grow over the next 5 and 10 years. The one exception is neurosurgery and neurology. For outpatient, most areas are expected to grow, so the shift to outpatient will continue. And here are some of the top areas that will continue to shift towards outpatient. So last week, as you all know, Israel gave a talk at the City Club, and he identified a number of areas, areas that disproportionately impact patients that we serve that require our focus. So these are some of the stats tied to that in terms of, and it amplifies a lot of what Dr. Rubin went through in terms of patients and populations that we serve and some of the health outcomes that need to be addressed. And I'm going to pause there. It's 3 on the dot. Chair Taylor, do you want me to stop right there?
Yeah, let's pause there. I see that there's one question. As Andrea indicated, she went through the information quickly here. We'd asked the directors to actually review the information in more detail, and then we will pick up with Andrea after we recess in the next meeting. But I see we have Director Ketting. You've raised your hand previously.
Yeah, although we could carry this over to the next meeting too. The point that I want to make at a very high level is that the most of the information on utilization really looked just at the last year, but that information needs to be seen, says, in a broader context, namely, what are the long run trends with regard to inpatient utilization, and what are the implications for a strategic plan, which of necessity needs to look more to the future. And Andrea gave me some information earlier that showed that what we all know is that the number of inpatient admissions has been on a long run decline, and that continues to decline and probably will in the future. In the advisory board information there, every one of the, all but 2 rather, of those categories show that there will be long-term declines in inpatient admissions. So when we think about our strategic plan, we really need to think in a historical and future-looking perspective when we're making decisions, particularly about capital.
Absolutely. And I would just add one thing. It's capital and operational because a lot of things are moving to outpatient because we're doing things like that our hospital has to adjust to do things like ERAS, to do mitigation teams to be able to do appropriate and early on-time discharge. And if we don't, we'll get left behind and our inpatient rates will start to go down. So it's really it's an all encompassing thing. We have to do what we need to do, knowing that they're not going to want to pay for that at an inpatient. And if we do, we'll be at a disadvantage. So we also have to implement the strategies to make sure we're able to turn around patients quickly and move to that kind of a tempo. And I think that's part of it as well. We definitely do have an eye on that, and we'll be working very closely to monitor that.
Thank you, Director Keding and Israel, for highlighting that. And thank you, Andrea, for providing the update, and we look forward to continuing the discussion. The Secretary is polling the directors for a date to continue this conversation the week of April 4th. If there are no other questions or further discussion needed on the information presented today, I believe we're ready to recess the meeting. Seeing no further questions or comments, this meeting is being recessed to the call of the chair. It will be reconvened sometime the week of April 4th. The Secretary will issue the public notice that the meeting is being reconvened no less than 48 hours of reconvening. Thank you all. We are recessed.